Good afternoon for everybody. We didn't bring the bell. Good afternoon once again, and on the behalf of the university and the faculty leadership, it is my absolute honor to welcome you at this opening session of the three-day reunion to celebrate the 40th anniversary of our English-speaking medical training program at the University of Szeged. I am Ferenc Peták. I am chair of the alumni committee, who was the major organizer of this event. That's why I'm here in front of you to open this session. And I am also the Dean's Commissioner for the Admission Affairs at the Faculty of Medicine, University of Szeged. It is my privilege to introduce you the distinguished representative of our university and faculty leadership, Professor Marta Széll, Vice Dean for Strategic Affairs. Thank you. Professor György Lázár, the Dean of the Albert Szent-Györgyi Medical School. And Andrea Lehoczky Balog, the head of the admissions office. I can tell in the name of all of us that we express our gratitude to all of you to accept our invitation and for joining us on this memorable occasion. We are especially delighted to welcome alumni from the very first generation. Started the university studies in 1985, a long time ago, 40 years ago. We have, if I'm correct, 2 representatives. I think only one here. Thank you. It is equally heartwarming to see alumni whose children have chosen to follow in their footsteps by joining our medical school. I met already 2 of them. Thanks for coming. And we also extend our gratitude to see siblings studying here together, continuing a shared journey in the medicine within one family. Your trust in our community across generations is a true honor, and we are proud to share in this tradition with you. We all hope that the academic and social programs of the current event will allow you to recall cherished memories, renew personal and professional bonds, and to create new friendships that will all strengthen our community. And now I invite Professor Marta Széll, the Vice Dean of the University, to deliver, Vice Rector of the University, sorry to say, to deliver her welcome talk, please.
Thank you very much for the warm welcome. Dear colleagues, dear guests, on behalf of the Rector and the management of the University of Szeged, I would like to warmly welcome everyone, but especially the alumni who have come at the invitation of the medical school. Over the next 2 days, there will be much talk about what the launch of English language medical training 40 years ago meant for the medical school and its students. However, now I would like to share with you a few thoughts on how important this step was for the University of Szeged, which consists of 12 faculties. For many years, the medical school fought a lonely battle to establish the legal conditions for teaching foreign students, recruiting students, developing an English language curriculum, and motivating the teaching staff. However, by the early 2000s, when internationalization became one of the most important priorities in Hungarian higher education, the many years of experience accumulated at the medical school had already laid a very good and stable foundation for the expansion of foreign language education at all faculties of our university. As a result, 1/5 of the students at the University of Szeged today come from abroad. Of our current 25,000 students, 5,000 are enrolled in English language programs and come from more than 130 countries around the world. None of this would have been possible without the thoughtful determination of the founding fathers who launched English language medical training 40 years ago at the medical school. For this reason, the entire university community owes them a debt of gratitude. We all remember those pioneering years with gratitude in our hearts. With these thoughts, I would like to conclude my speech. I wish all of our alumni a wonderful weekend. May you recall your memories with your former classmates and teachers about the struggles and joys of your years spent here in Szeged. And share with each other, of course, your experience from your medical career. Thank you for your attention.
Thank you, and I invite Professor György Lázár, the Dean of the Albert Szent-Györgyi Medical School, to welcome the alumni.
Thank you. Dear alumni, colleagues, and friends, it is my great pleasure and honor to welcome you back to the Albert Szent-Györgyi Medical School. The reunion is a very special occasion. Not only do we celebrate the bonds of friendship and professional achievement that unite our alumni across the world, but we also mark an important milestone, the 40th anniversary of the English language medical program. For 4 decades, this program has brought talented and ambitious students from every corner of the globe to Szeged, creating a truly international community of learning and discovery. Many of you here today were pioneers on that journey, and all of you have carried the name and the spirit of our school into hospitals, laboratories, and the communities worldwide. We are immensely proud of all of you have achieved, and we are deeply grateful that you have accepted our invitation to return and share your experiences with us. This 3-day reunion offers a chance to reconnect with old friends, to share memories and accomplishments, and to celebrate how far we have come together. It is also a moment to look forward to the future of our school, to the new generation of students who will follow in your footsteps, and to the continued excellence of our education, research, and service to society. On behalf of our faculty, the staff, the students of the Albert Szent-Györgyi Medical School, I warmly welcome you home. May these days filled with joy, inspiration, and renewed connections, and may these celebrations strengthen the ties that bind us as one community across the world. So, thank you again, and let us celebrate this milestone together. Thank you very much.
Thank you, and now we will continue our program. We are a little bit ahead of schedule, which is good for all of us, with the continuing medical education session, where lectures will be delivered by our excellent alumni, and I would like to express our gratitude for accepting our invitation and giving talks on this session. And this session will be hosted by my colleague Andrea Leotsky-Balog, Please welcome, please pay attention, and I can see that in the back rows our very precious current students arrived. They are very curious about the talks. And I encourage them to collect questions, because at the end of this session, although there is a strict timing to get into the mayor's office, but according to the schedule, there will be a roundtable discussion which may be partly academic, partly a kind of friendly topics we can cover. So, Andrea, please.
So good afternoon, everyone, and welcome to today's continuing medical education session. We are very honored to host 4 distinguished speakers, all of whom began their medical journey within the walls of this institution. It is a privilege to welcome them back home to their alma mater. Each lecture will last for 20 minutes and will conclude with a short quiz. The quiz questions are placed in front of you. All CME courses are accredited, and certificates of attendance will be issued to participants who submit the completed answer sheets. So those who need the credits, please complete the quizzes. And also please remember to write your name clearly onto the sheets so that we know who you are. Okay, so there will be no breaks between the sessions, but we will close with a roundtable discussion, as Professor Peták mentioned. And this will follow after the 4th presentation. So let's start. Our first speaker is Dr. Eleni Episcopou, a graduate of class 1998. Dr. Episcopou is a senior anesthesiologist at Metropolitan Hospital in Athens with 16 years of experience performing approximately 100 surgeries per month across multiple specialties. She has completed more than 2,500 video laryngoscopies, pioneered Greece's first stellate ganglion cryoablation for refractory arrhythmias, and is highly skilled in ultrasound-guided interventions and pediatric anesthesia, particularly for children with autism. In addition, Dr. Episcopou is an interventional pain specialist with international trainings and certifications. She's also an educator, textbook author, and faculty member of the World Institute of Pain. Please join me in welcoming Dr. Eleni Episcopou, who will present cryoablation in pain management and palliative care.
Good morning. It's a great privilege to be here. We had a discussion yesterday that this university really gave us the guidance how to behave, because at our year it was a really tough training, but how you appear giving the exams to the professors and how you behave during your medical student life, this is making the doctor of tomorrow. Thank you, all the professors, for what I am today, because this is from Szeged University. Thank you very much. So, when I was a student here, I was interested in pathophysiology and in arachidonic acid cascade, where was my thesis. And I think cryoablation has a big connection to that, even for the tumors that I would like to present. 20 minutes is not possible, but I would like to focus in the procedure and in pathways and what we have updated. So I started studying interventional radiology during COVID. And because I thought, as I am an anesthesiologist, and in 2009 I started pain management, traveling all the world, but I finally, 2018, I came back to Hungary. So I had a fellowship in Budapest for pain specialists, and this was a motivation for me to do interventional radiology, because in Greece, as anesthesiologists, we cannot do the procedures. So for every advanced interventional procedure, we have to have ethics based in evidence-based medicine. And what we have to think is we don't have to over-treat a patient, because doing a procedure will put a patient life in a risk, or to under-treat a patient because we don't have the knowledge how to treat him, and we leave the patient in pain. From the last years, what is very important, and from the past education, is focus on the patient, the history, the physical exam. Then this guides us to differential diagnosis, and we confirm the diagnosis with the imaging. And the last years, for each procedure, the selection of the patients is very important. The information to the patient and the relatives, what they have to wait about the procedure, and multidisciplinary team consultation, because these patients, when they arrive in pain clinics, they have a long history, and all the people involved for pain management have to take a decision that we can make an interventional and precise therapy for each patient. So this started from my country, that is Psychrolusia. Psychro, it means cold, and it comes, and luo, it's luome, it comes from the Greek word that I am embedded to cold. So it's all started there, and I think the history will drive us to progress. And if you find in the literature and you search, you can see what is cryoablation. It is low temperatures that we applied for killing the tumors, while cryoneurolysis is a part of neuromodulating technique that we apply for the nerves. And these all have with a connection for the cryo-injury, that this is used for damaging living cells and tissues during the progress of cooling, freezing, and storage. So how it works? It works with the Joule-Thomson phenomenon, that there's a gas. It depends which gas we can use. We can use nitric oxide or argon or carbon dioxide, that it passes from high pressure through a throttle to lower pressure, and as it's passing in the resistance through the probe, it is coming to the tip of the probe, where this decreases the temperature, and this creates the ice ball. Sorry for that. You can see that there is different probes and different eyeballs that they are producing with different machines and different size, depending on what you would like to cryoablate. So it can be applied also of peripheral nerves, and this is a kind of injury of peripheral nerves that we know with Wallerian degeneration. It's like an axonotemsis injury that we provide with the eye crystal formation to the axons, but it remains intact, the endoneuron, perineuron, epineuron, and the sheath. And these have a contrary effect when you are comparing with the RF, because it was used RF ablation method with heat, that it was causing neurinoma, but with cryoablation we have this advantage that neurinomas are not formed. And usually the analgesic effect is from weeks to months. How this can be applied, updated now. It can be applied, the cryoablation, for cancer and non-cancer patients. Concerning the global cancer statistics, we can see that to 2050, the cases of cancers that will appear, it will increase. And according to WHO, the leading cancer is lung and breast cancer. But the people, as the year passes, the people that are dying from cancer reduced. So when I was reading, I was asking myself why this will happen. Is this the medication? Is the approach of the oncologist? Is the combination and the procedure that we perform for tumors? And then I start reading the literature, and in modern oncology, the pain that it is caused, it can be by the tumor itself. We can have peripheral neuropathies, that it is a result mainly from the drugs. It can be caused by radiation-induced pain, or musculoskeletal pain, or chronic post-surgical pain. How it works? Usually, we put transcutaneously a needle. Before each procedure, you have to be prepared, you have to study each patient, you have to discuss with the radiologist, and you have to place the appropriate probe in a tumor, at the point of the tumor, it will create two zones of freezing. This is the central zone and the marginal zone. At the central zone is very important because they are killing the cells, and what it's causing. This is like a vaccine, a local vaccine against tumor cells. And how this has happened? When we freeze, there are damaged cells. These are called DAMPs, and these are very important for two things. The one is that they're creating inflammation by activating the neutrophils, macrophages, and natural killers. And the second is that they stimulate them, activating the major histocompatibility complex 1 and 2, and by this activating the CD4 and CDA helper cells, that these, with the immature dendritic cells that are in the area, these are becoming and moved from afferent lymphatic tissue and become mature to the distance, and by this way it is causing the ascorpal tumor effect. What this means? That the cryoablation is not killing the tumor locally, it's only producing an inflammatory process that can decrease the metastasis and can affect the distant area. What is very important, and this have been found, and I will show you the papers, is that in the marginal zone, because even we are not planning and even the cryoablation is not correct, we don't have coagulative necrosis. We have apoptotic cells, and these are not killing the tumor. This can induce a promotion of the tumor. So we have to see and combine, because this can make a toleration, and this they found that this gap, that the cryoablation is not good. It can be added the anti-PD-1 injections, and you can combine cryoablation with the immune checkpoint inhibitors, and then you can have a better result. This is, if you understand all this pathophysiology, then you can treat the tumors. So it was very important by Ferugatti on 2024. It is all the analysis concerning the tumors, but what is very important concerning the cryoablation is how the nerve growth factors and in innervated inflamed tumors, they are making an in situ vaccine, so they can block the tumor, and you can kill the tumor. There is an evidence gap, and they say that before each procedure, we have, first of all, have a multidisciplinary team and see the patient, see where is the tumor, how we will apply the needle, which needle we have to correct, and we have to check biomarkers in order to have a successful results. This can be from the serum. We have to study with the imaging the amount of nerves that are around the tumor, and we can have we can measure the NGFs. But now there is no available data, and there is a gap. So when, how, and for how long we apply, and what are the side effects? Because if we're doing a procedure, we have to know what the side effects and what we have to treat after that. We can do cryoablation. We can find in the literature for lung tumors, liver tumors, for bones, for kidneys, and for prostate. Each of them has complications. Especially in the lung, we have pneumothorax and hemoptysis that we have to be aware. In case of bones, we have fracture of the bones that is very important. And in case of prostate, there is an erectile dysfunction. And the most rare complication, it is the urethroperitoneal fistula. But the most important is in liver cryoablation. That this is causing a cryoshock, that is a life-threatening procedure for the patient, with the increase of a cascade of cytokines. But the technology now in the ER units, it helps us a lot because we use ultrasound machines with intravenous contrast. We can see where is the tumor, and we can combine this placing the needle, and then with CT guidance, we can ablate at the liver area. Thank God from all the people that they are appearing to be candidates of cryoablation. This will happen only in 0.3% of the patient, and it doesn't happen ever below the 3 centimeter. So, for the lung, that is a major leading cancer, even in males, in the females. As I stated in the beginning, they study all the inflammatory cascade and the distant metastasis and how you can combine. This is the last from eScience. This is how the hybridic techniques can be combined with multiple lung cancer, and how you can approach this patient, how you can combine with VAT surgery in order to have better result. This is this procedure until this moment. It has happened under CT guidance with local anesthesia, with sedation with the anesthesiologist. That you make this procedure under sterile condition. Then you, as you can see in the video, you can place the probe, and you can ablate the tumor. And usually this patient have to stay in the department for 1 day for follow-up and for seeing if there is complication of pneumothorax. We usually follow up them in 2, 3, or 5 hours. So what we can find that even in interventional radiology, although there is at this moment percutaneous cryoablation, with EBUS, and with it can be done bronchoscopic cryotherapy, and you can find in the literature now this can be robotic assisted procedure, so we can have procedure and the selection of the patient. The procedure is appropriate for the selection of the patient. And there is follow-ups for our patient, and at least in the clinic for 12 months with very good results, going to be published. So according to breast cancer in 2022 and 2024, as I told you, this promoted the cryoablation procedure. It was combined with immune checkpoint inhibitor, so we reduce the gap of the marginal area, and this can cause a local and a distant effect. It is really an easy procedure that it is happening with ultrasound under slight sedation, we are putting the probe under local anesthesia and you can freeze the tumor. There are data for following up at least 6 months procedurally. And what about this is, I didn't put all the kidney and the prostate because of the time's sake. So these are the major tumors that we can do cryoablation. Then for non-cancer pain management, where, which, and how we can apply. If we see the guidelines in the literature, there is preoperative, intraoperative, and postoperative. It can be applied into the joints and to the peripheral nerves. Throughout the history, and because it was very challenging, it was the knee joint that it was very important, and this was a study from 2016 to 2024 that the patient underwent cryoablation, and they had at least postoperative 6 months less pain and less opioid consumption. And there is a protocol that either to schedule, it was a problem actually when you will apply in the beginning the cryoablation before the procedure. So they standardized that 3 to 7 days, and I can say 7 days, it's the best period before the operation for total knee arthroplasty that it can combine with a ductal canal block. And then in patients that have either postoperative or patients that cannot be treated because of comorbidities, then you can do the cryoablation procedure with very good results. But where we can find in the literature that it was mentioned that you can block the genicular nerves, you can do combined with infrapatellar. There is no strict guidelines what you have to treat concerning that, but from my approach, this has to be precisionally made to the patient. You have to study the patient, examine, see the imaging, and then decide, even scan with the ultrasound, with musculoskeletal ultrasound. You can see entrapments, that it means the nerves you can see in the ultrasound, it is bigger. It is a really easy procedure under the ultrasound and the cryoablation. During the procedure, even when you are putting color Doppler, you can see the ice ball creating at this area, and it is amazing that if you select and do precise the procedure, then the patient is coming, could not move, and then when he stands up, he can move and walk, and it is amazing because we usually put them to climb stairs, and they are feeling very good. So postoperative, depending on the way of approach and depending on the operation, this was before, I think, because now robotic-assisted operation of the knees doesn't cause this damage, but infrapatellar saphenous neuralgia is a neuralgia that we can see post-operative. And you can really, as I told you, you can see if there is an entrapment. It's like when you put a ring in your hand, and this is very small, then you can see a swelling and edema in your hand. This is happening also in a nerve, that if it is entrapped in the fascia or if it is traumatized. So the interventional radiologists come and say, but why should I do a cryo? And I'm not doing embolization in osteoarthritis. And they stated that I can do, due to it depends on the osteoarthritis stages, because we have 4 stages, and we have new vessels, new vascularization in the joint. Then they state, oh, we can do embolization of these arteries, and then the patient have the same results. Although in the literature, we don't have comparative RCTs and good quality studies saying that cryo or embolization is better one another. And what is my favorite is concerning shoulder denervation. I think we have many friends here that are orthopedicians. What it used to be, it was mentioned that it is, first of all, conservative steroids, and then all the patients are going for operations, and then for arthroplasty. But now what it is proposed, that after the conservative measures, maybe depending on the age and the state of the patient and the comorbidities, we can do orthobiologic injections and not steroids and not hyaluronic acid. Then can be transferred for surgical, and then we can do a minimal invasive intervention. And this can be done even in patients that cannot go for a shoulder arthroplasty. This is, there is a lot in the literature concerning the sensory innervation of the shoulder. The major nerve that is making the innervation is the suprascapular nerve, but the lateral and the low subscapular and the axillary nerves are also part that we have to ablate in order not to have partial denervation. How it is done? The suprascapular nerve, as it is going in the fossa and the glenoid, they are giving two branches, and we have to ablate here. This can be done very easily with the ultrasound, and the posterior part, we see the inferior part of the suprascapular nerve and the posterior branch of the axillary nerve. Sorry for the delay. Then there's the lateral pectoral nerve that usually it is accompanied by the lateral pectoral artery that is between the coracoid and the clavicle. And you can see now there is updated literature that there are even small branches along the coracoid process that you have to denervate. And what is the most important when you denervate the shoulder joint is the anterior parts, because it is the brachial plexus. These are the way that you can do with the ultrasound. I will not speak in details, but it's really, if you are trained, it is easy. This was done by my Hungarian teacher in Budapest. And this is my favorite, the stellate ganglion block, because after COVID, I had the chance to do during COVID in a patient that he was 64 years old, and I called in the department. He was implanted with a defibrillator, and he was supposed to die, and the anesthesiologists on the department, they were performing continuously every 8 or 9 hours stellate ganglion blocks. So we did a cryoablation. It's an easy procedure with ultrasound and CT scanning. And this is the article, and the patient is still alive, even after these years. Lastly is, because I don't know in Hungary, but in Greece, the population is a little bit fat and everybody's taking Ozempic. I found a trial concerning cryoablation of vagus nerve, and it was easily done. And with the new AI techniques and the new ultrasound appearance, you can see very easily. Then for peripheral neuropathies, the sympathetic chain is very important, that either in cancer patients after the chemotherapy, this is a patient of us for post-radiation neuropathy, that you can see the scarring after the radiation, and we performed the cycle of cryoablation, and now the patient, even 1 year after, he's fine. What is very important that I have to mention as an interventionist is the variation, even from left to right side, as we learned here in anatomy, and the variation and where are the nerves, and for each patient it's the most important. And we performed for peripheral vascular disease that the appropriate needle position was that for this patient, and it's going to be published, and this was for intractable pain in peripheral vascular disease. This is how we do with 3D CT during the procedure, and we can combine even with CT, and we combined also with ultrasound. This is my favorite because when I start using the ultrasound, I thought that I was doing the procedure correctly, but when you put the contrast and you make a fluoroscopy, you see that the contrast is going to psoas. So you have to move the needle and put the needle in appropriate position in order to ablate the sympathetic chain. I think AI is going to make our life easy and better. I believe in that. It can be applied in oncology for each oncological patient, guide us which procedure we're going to do and what is appropriate for the patient. And I hope that we will have the data for pain management, that we can select the appropriate procedure for each patient. And what is my big question, as it is for cancer, that there is a gap. Can we make a gap at which age that we can cryoablate an area or a nerve, a joint, and how we can combine with good quality PRP exosomes in order to regenerate the joint? But what is the age? And there is no literature concerning that. So I would like to thank that his dad is Professor Gaborax, that I met him, as I told you, here in Budapest. And this is Agnes Togica, that she is Hungarian also, so that this guided me all these years since 2018. And this is Arpad Gece, that was my professor for pathophysiology, pipetting all day and night in pathophysiology department. And nothing will happen that my daughter is following the lecture. Thank you very much for the support.
Thank you very much, Dr. Episcopou, for your presentation. Our next speaker is Dr. Ahmad Nama, class of 2009. Dr. Nama is head of emergency medicine at Hadassah University Hospital and a leading figure in Israel's emergency medicine community. He serves on the committee of the Israeli Association for Emergency Medicine and completed a clinical fellowship in emergency medicine at the Royal Melbourne Hospital in Australia. At Hadassah, Dr. Nama co-coordinates the academic emergency medicine program and lectures at the National Israeli Course in Emergency Medicine. He's also the founder of the AMIS Academy. His contributions have been recognized with multiple awards, including the NICEM Appreciation Certificate and the Outstanding Employee Award in 2020. His expertise includes emergency ultrasound, critical care, area management, and peripheral nerve blocks. Please welcome Dr. Ahmad Nama with his lecture, Sharper Eyes, the Evolving Role of POCUS and AI in Emergency Medicine.
Thank you. First, it's a really exciting moment for me to be here. Dear Dean, Professor, colleagues, students, the admission office with Andrea, Varga, Vanda, and Sylvie, and everyone. It's really, thank you for being here. And as Eleni said, to be in the Hungarian Institute and to learn in Szeged, it's not only about taking an MD home. I think it's all the values, the experience, and the knowledge that I have here. It's a lot. It's thanks to you. So it's a way of living and a way of we represent you abroad. And I can tell you that most of the time when the exams, this is the, the stressful moment for us. When we used to go, when my friends ask me about the Szeged University, I tell the honest truth that they won't let you leave the country with not enough knowledge, because we hear that a lot of time, you won't pass this exam and go home and make us shame, You have to go always with the best knowledge. So this is something that I always take it with me. So thank you for having us, and thanks for all the alumni group and everyone here. So I work for Hadassah Medical University Hospital. It's located in Jerusalem, heart of Jerusalem, in Israel. We have 2 campuses, 1,300 beds. We are part of, affiliated with the Hebrew University. We have two campuses, the Ein Karim campus and Mount Scopus. Ein Karim's campus is basically the main one. We have a trauma level 1 center, and roughly we see 100,000 patients every year. This is, I have been directing this emergency medicine department for the last 3 years. So if we just quickly look at the, I think it's not all the, disconnected? You don't see the whole picture. So sorry. So the Australian College for Emergency Medicine, they defined emergency medicine as a specialty that gives the doctors the enough equipment for knowledge skills that require for the people to treat people in life-threatening situation and in urgent healthcare needs. So what is unique about emergency medicine, just as an introduction? The unique about emergency medicine, that it's a dynamic specialty. The environment, it's most of the time, it's challenging. We don't know who's the patient is coming. So we work all the time in a challenging, dynamic place. And the most important thing, that time is an issue. So time is brain, time is heart, time is sepsis. There is KPIs that we need to chase them all the time, right? So we need to give antibiotics in time. So all of this environment put us in a place where we have to make decisions, clinical decision makings. They have to be quick, they have to be accurate, because everything that we don't make the right decision, there is really consequences. And based on this, we rely on many things. So one of the things that I want to, this really 20 minutes give you a talk, is just to touch a little bit about the point of care ultrasound, which is, it's a cost effective, it's an ultrasound, it's portable, it has many wider clinical use today in the emergency medicine departments, and there is nearly no side effects unless you really don't know what you are doing. So it's operator dependent. Lately, there have been some infection concerns, so you need to make sure always clean your probe before you reach your patient. But if you look back, it's not something new. So point-of-care ultrasound have been introduced in medicine. First, one of the things in emergency medicine is the fast exam. So patients come with trauma. The thing that we look for is basically, we just want to take the probe, reach the patient, and look for intra-abdominal bleeding. This is the base. This is where all started outside the radiology department. And then quickly we understood, so there is roughly four places: the Douglas pouch, the Morrison pouch, is there any bleed between the liver and the kidney, spleen and the kidney, and there is also a pericardial window. Okay, so this is a fast exam. It is fast. It takes usually less than 1 minute to do it, even properly in experienced test. And then we moved from, okay, we understand we can do fast, let's do central lines. There is no reason today to do a central line in a blind technique. Sometimes we still do it subclavian in trauma settings, but every ultrasound today, it's an ultrasound guided. So took the ultrasound, take the probe, okay, let's put internal jugular and femoral. And then the list goes on and on. Like in medicine, you know, there is no limit for things. So now we use ultrasound to understand a little bit more hemodynamics understanding. We do all the pleural peritoneal aspiration, ultrasound guided. Patients come with abdominal pain to the emergency department. We take the probe, we look at their gallbladder. We are not replacing the radiologist. We are just a tool that we want to have our best clinical decision making. And something more, it touched a little bit Eleni's talk. So we have been doing many regional nerve blocks inside the emergency department. So we block every nerve. Mainly patients come with femoral fracture. They don't go to the ward. They are not admitted without doing a regional nerve block for the femoral nerve. And then from there it started. When I started that in 2019, quickly we moved from the femoral, now all the chest injuries, rib fractures, we do ultrasound guided blocks as well, upper arm, lower arm. And recently we even added a facial blocks for patients that they come to the emergency department. Of course, you know all the consequences with less opioids, less morphine, patients have happy patient, everyone is happy, right? So this is everything is done ultrasound guided, and there is more and more. So, and the one extra thing that I like about point of care ultrasounds as well, it's not very hard to learn. So even if you just look at the A in the left side, you see that there is a heart, lazy heart, barely pumping, right? So this is the pump. This is, by the way, a part of the rush protocol, rapid ultrasound in shock. So every patient they come, there is a protocol where to look and what to look. So we look at the pump. Is it pumping good? No, it's lazy. Or is it normal? So there is also some features that we can look at the mitral valve. If it's kissing the septum, it means the ejection fraction is above 50%. We have a cardiologist in the audience. Don't chase me with that. So, and the last one, you can see that it is hyperdynamic heart. So hyperdynamic heart, is a patient septic? And always you have to remember, this is your stethoscope. This is a tool that you have to combine it with the clinical scenario. You cannot just send me a video and ask about a question if we don't know what is the clinical question, right? The radiologist, usually when you send for a CT, they will tell you what you are looking for, right? It's not just a CT. So here it's the same. So it's a hyperdynamic heart. Is it early stage sepsis? This patient needs a lot of fluids. Then we can look and extra things. So it's easy. You do more and you learn more. And one other thing we moved, so remember the FAST. The FAST started only in the intra-abdominal cavity. Here we are talking about extended FAST. So today we do lung ultrasound. And the lung ultrasound, also here it's not very complicated. Clinical scenario, you look at the left side where there is pleural sliding. Air, you cannot see air in the ultrasound, but pleural sliding, you can see it. So if a patient comes to the trauma bay with trauma, and we look at the lung, and he have a shortness of breath in instance, and we look at the lungs in specific points. If the pleura is sliding, there is like small ants are walking under the pleura, plus there is a seashore sign. It looks like a seashore. It means at this specific point where I put the probe, there is no pneumothorax. But on the other hand, if we see a barcode sign with pleura which is not moving in the picture in B, and sometimes even we can see the lung point. So there is a sliding lung, and then in the other hand there is non-sliding pleura. So this is 100%, this is a pneumothorax. There is no argue about it. So these things, it help us clinically to decide what we can do with our patients. So everything, it's bedside, it's easy, and we can teach. And one more thing, as I said from the beginning, we can understand more the hemodynamics. So the shocky patients, are we giving them more fluids? Or is it time to move to vasopressors? They give more adrenaline, less adrenaline. So there is like clinical questions that it can be helpful. So what we can do, basically, this is the old school JVP, elevated, not elevated. Here you can take the probe, look at the inferior vena cava, and if it's collapsed, this patient is definitely hypovolemic. And if it's not collapsing, these patients are eovolemic. Maybe if they are in shock, maybe this is the right time now not to give fluids. You need to move to vasopressors and et cetera, et cetera. So this is more or less, it's a physiology. It's understanding the clinical patient, putting the image together and move on. So there is many protocols today that exist. Rapid ultrasound in shock, point of care ultrasound in cardiopulmonary resuscitation, etc. So there is, everyone brings a protocol, they name after himself, and they just publish it. But at the end of the day, they are the same thing. You need to know what you are looking for, how do you combine it. And one thing that I want to introduce to you is the point of care ultrasound in a patient that they come sick, in CPR, active CPR, or they come sick in the department, and we call it, it's one of my colleagues from India, he call it's a trap. You know the 4 H's and the four P's. You need to look for H and P in CPR. So here we took it a little bit. As emergency physicians, our attention span is not very high. We need very strict, very straightforward questions. And we say, is it a trap? It means if I have a patient coming sick or in a CPR, this is the resus room in my department. So the ultrasound is there. And the CPR, if it's active CPR machine, of course, I have nothing to do with the machine as in marketing for it, but this is a great CPR corpus machine because once it's connected to the active patient, it gives us extra hand. I don't need more people to be involved to do the CPR and give me more place also to think and to act. And I know that this CPR machine is doing even better and I can control it, CPR than human CPR, okay? But the ultrasound machine, why it's there? Because in between, I can do the evaluation, I can check, and then we can do a clinical decision making. So there is a place where this ultrasound should be put. So for example, let's just give some clinical scenarios. So a patient present to the emergency department with pre-syncope or syncope, weakness, low blood pressure, etc. One of the things we can do an ECG, and what you can see in the ECG, by the way, we can see it's sinus rhythm, there is pulsus alternans, so the R wave are not the same. This is suspected for pericardial effusion, okay? Tamponade is a clinical definition, but this is suspected for pericardial effusion, and for example, this is how this is how a pericardial effusion looks like, okay? And you see here that the heart is doing a lot of sports, right? So it's a hyperdynamic heart. There is pleural, there is pericardial effusion, circumferential for the whole, and this you need to combine it with the clinical scenario. Is the patient in shock? And this is probably a clinical tamponade. Maybe we should proceed for pericardiocentesis. Or no, it's not, the RV is still fine, it's not a tamponade, and maybe we should look for something else. So this is how the dancing heart can see in the ECG, and if needed, we need to do basically, sometimes this is not very common to do pericardiocentesis bedside in the emergency department, but sometimes if the patient not, I think in every big institute, these patients are enough well to take them to the cardiac cath lab or to do it upstairs. But sometimes, I can tell you in the last 2 years, we have done it 2 times in the emergency department because the patients were not enough hemodynamically stable to move them anywhere, and given the fact that also we have a large oncology center and hemato-oncology center, so these patients, they can walk and they can tell you, I feel bad, I don't feel well. They don't necessarily come with a shock, and then their blood pressure is 70 or 80 systolic blood pressure. You put the probe in the chest and there is massive pericardial effusion because usually it's not acute, it's accumulating. That's why they compensate. So every patient we need it. So from the trap, it's a trap. We start with the T. We look for tamponade. This is another patient this is ongoing CPR. So the machine is connected with a patient. We are doing active CPR, and you can see many things here. You can see that there is definitely large fluid, which is hyperdense. It means it's a blood, it's a trauma. So there is positive thoracic spine. You can see the thoracic spine sign. There is a lot of fluid there. Of course, we will chase the protocol in trauma. I don't need an ultrasound to proceed there. But the patient is intubated now. We need to do traumatic cardiac arrest protocol. We proceed from this, just for this. We finger thoracostomy, put the chest drain. If needed, we open the chest. You know, it's all, we prove what we want to do. So we see everything under vision. So we say tamponade, tension, hemothorax tension, pneumothorax. It could be also a life-threatening situation. This is the double or triple trap, the T. And then we look also, we need to look always, any chest pain, any patient in CPR, any patients come with shock, we have to look at the right ventricle. We need to do point-of-care ultrasound for the heart. How much time I have? So we need to look, I'll make it quickly. So we need to look at the right ventricle, because if the right ventricle is enlarged, it means there is RV strain. RV strain maybe need thrombolysis or systemic or angio-induced. So this is it's not a trap. We look for RV strain. And also sometimes, you know, instead of checking the pulse for a patient, CPR every 1 or 2 minutes and look for the pulse, sometimes I mark it even, you know, I just put a marker that this is the femoral artery. You can stand with the probe, and you can stand with the probe, and I mark it, and I know where to look. So today, there is enough literature, even how to integrate this point-of-care ultrasound in this patient. So this is typically how resus room with ultrasound, with everything should looks like. So to sum up, we look for that it's not a trap. We look for the tamponade, tension, pneumothorax, hemothorax, RV strain, look at the activity, and make sure that you see under vision everything. So one more thing, so this is for the point-of-care ultrasound. The other thing that I just want to mention, many of the clinical decision-making that we make also, today you spoke about AI, you know, most of the CT machines today and many of the radiology tests that we do, it affects us in the emergency department. So here, you don't need to be, you can see that there is a pulmonary embolism. It's big pulmonary embolism. Ziad immediately saw it when he said, but today we have tools. It's within seconds, within 1 minute or 2 minutes, we send the patient to the CT. They come back, and then we can see that this is pulmonary embolism positive, okay? So why I'm mentioning this? Because at the end of the day, it helped me in the emergency department. And the question always when we use AI in radiology, we need to say, if it's a negative test, if the machine tells me that this negative test, there is no pulmonary embolism, most probably there is no pulmonary embolism. But if I have a positive test, like here, then we should rely very much on this and don't discharge this patient, or don't make your decision making based on a machine that is giving you that there is a positive test and you are taking a challenge for negative test. So we can see for pulmonary embolisms, today we have the ability to look for free air. So patients coming with abdominal pain, we send them for CT. Really, after a few minutes, we have a result of free air in the abdomen, yes, no. We can see brain aneurysms. We can see occlusions in the MCAs. And we can see also fractures, rib fractures, any fracture, also in the chest X-ray. So all of these basically affect us in the clinical decision making. So just to sum up, we are living and evolving in an era where patient management, it's not blind anymore. You know, you should rely on your portable things that we do at bedside. AI, it's part of our life, and we have to take it forward. We should learn the protocols, how to do these things, and everything should be under vision. You are all invited to join us. We have a course, a skills course with nerve blocks and critical care blocks that we do it in Europe. Hopefully we can get it in Hungary as well. And you are all invited also for a yearly conference that we run international in English in Jerusalem. I hope, and if you can make it, you are all welcome. And thank you very much.
Okay, so thank you very much, Dr. Nama, for your presentation. Okay, so our third speaker is Professor Haralampos Doulis, class of 2003. He is professor of neurology and neurogenetics at the University of Bergen and Haukeland University Hospital in Norway. Professor Doulis serves as director of the NeuroSysMed Center of Excellence for Clinical Neurological Research, head of the Decode PD Research Group, and director of both the K.J. Jepson Center for Translational Research in Parkinson's Disease and the Mons Center for Neuroprotection. An internationally recognized expert in movement disorders and neurodegeneration, Professor Doulis has made pioneering contributions to the understanding of mitochondrial dysfunction and NAD metabolism in Parkinson's disease. He currently leads several major translational and clinical initiatives, including national and international multi-center therapeutic trials. So please welcome Professor Haralampos Doulis with his lecture, Disease-Modifying Therapies in Parkinson's Disease.
Thank you so much, Andrea, for the kind introduction. Hello, everyone. I'm truly, truly honored and deeply touched, I have to say, being here. It has been so many years, and I just arrived yesterday, and you know, I haven't really been in Szeged for decades. Sounds interesting, for decades. How fast time flies. And I walked the streets, and you know, it's truly an amazing feeling being back here. So my deepest gratitude to the faculty for inviting me. Thank you so much. It truly is a privilege being here again, back to school. And what an amazing school. So yeah, I'll tell you a little bit about what I do. I'm of Greek origin, as my name you know, says. There's a short version for my name, which is Harris, so please use that. Even though Andrea did an amazing job pronouncing my full name, I reckon that not all of you can manage that, and that's perfectly understandable. So I'm in Norway. I've lived in Norway for the last 23 years. When I left Szeged, I moved straight to Norway. And I'm a neurologist. I'm a clinical neurologist, but what I do these days mostly is research and quite a lot of administration. So I work with neurodegenerative diseases, and the topic of my talk today is about Parkinson's, which is the topic of my research group. Let's see, so is this? Ah, yes. The on button, the key to many things in life. So Parkinson's disease is one of the most common neurodegenerative disorders. It affects about 1 to 2% of everyone above 65. There is an estimated 10 million people with Parkinson's disease in the world today, and what is particularly alarming is that Parkinson's disease, it may only be the second most common neurodegenerative disease. However, it is the most rapidly increasing neurological disease in the world. So it increases, the prevalence and the incidence increase more rapidly than those of Alzheimer's disease. So based on these estimates, we think that around the year 2050, there will be 30 million people, so a tripling of the number of cases with Parkinson's within the next 25 years. Of course, Parkinson's affects a lot of people, including celebrities. Recently, this great musician, Ozzy Osbourne, the lead vocalist of Black Sabbath, many of you may know him, he passed away of Parkinson's disease, and he has been somebody whose music I grew up with since I was a kid. I remember sitting at the lecture halls with my good friend Ziad, who's right there, and I was drawing these black metal and heavy metal things on my notes, and my friends were making fun of me. I had long hair too back then. It was a different life. I don't have a photo. I couldn't find one. I also had an earring. Ozzy passed away, unfortunately, as you may have seen this year, due to Parkinson's disease. And another piece of sad news, I don't know if you recognize this man. This is Morten Harket, and he's a Norwegian guy. He's the lead singer of a-ha, so, you know, an enormous celebrity. And he recently came out with the news that he has Parkinson's disease. And I've known this because I'm his treating neurologist, and he allowed me to say this. I think Morten will contribute to the fight against Parkinson's with his celebrity status. So what is it we do at the centers that we have in Norway? These are clinical and translational centers. Our goal is to find a cure for Parkinson's. Our goal is to find a treatment that can not only manage the symptoms. We do have some treatments to manage symptoms in Parkinson's. Motor symptoms, we can use levodopa and we can use dopamine agonists, and these things will decrease and control motor symptoms to some extent. And I remember, learning all this by Professor Laszlo Vejce here in Szeged. I don't know if he's still here or if I could meet him. I hope I can. What we don't have treatments that can delay neuronal loss, treatments that can delay or stop or even reverse or even prevent disease progression. And this is the kind of treatments that we and many other colleagues around the world are trying to find. Now, how has this been going for us? Very poorly, because despite all these efforts, there still isn't a single therapy available globally that can make a dent, that can delay or stop disease progression in Parkinson's disease. The good news is that never before have there been so many efforts to find such a therapy. This is from a review from 2024, it shows the number of trials registered on clinicaltrials.gov all over the world in 2024, last year, and as you can see, there's 136 trials, half of which approximately aim to find a disease-modifying therapy. So this is, it means that the efforts are strong, and several of our trials are included in this figure as well. And what kind of mechanisms are being targeted here? So, Parkinson's disease is still a black box. We don't understand the pathogenesis. However, we do know of certain processes that are associated with the disease. And these are the processes targeted by these treatments that are being tested by us and others. And what are these processes? Mitochondrial dysfunction, so dysfunction of bioenergetics. Problems with proteostasis, the balance between synthesizing proteins and the breakdown of proteins, so dysfunction of the lysosomal apparatus and the proteasomal machinery. Problems with abnormal protein aggregation. In Parkinson's disease, this would be primarily a protein called alpha-synuclein. However, other abnormal proteins occur in Parkinson's disease, such as tau, such as beta-amyloid, TDP-43, proteins which you may recognize more readily from diseases like Alzheimer's, ALS, or frontotemporal dementia. These are overlapping pathologies, so we do have these proteinopathies also in Parkinson's. Neuroinflammation, abnormal activation or hyperactivation, the jury's still out, of microglia, the immune cells of the brain, the resident immune cells of the brain, and of course acquired damage of the genetic material, the DNA. So a few examples, the list is long. We now have about 70, when I say we, that's the world, not just we, about 70 negative trials of potential disease-modifying agents have we had in Parkinson's disease. So it's a sad story so far. And just to highlight a few, at least a couple which we had high hopes or expectations for. This was 2 trials of immunotherapy against alpha-synuclein, so the abnormal protein aggregating in Parkinson's, right? So here they gave patients monoclonal antibodies to remove this alpha-synuclein. And the results of these trials, unfortunately, were highly disappointing. There was no difference between placebo and active drug. That did not work, as simple as that, although there was perhaps suspicion of a subgroup of responders in this prasinezumab study. So Roche, being Roche, meaning having a lot of money, will go on with a phase 3 trial. I'm sitting on that panel. I advised against it, but the trial, do you know there's a term in clinical trials, too expensive to fail? Now think about that for a second. Absurd, but true. This is another disappointment we've had, and these are academic trials. These are trials of, somebody said, Eleni said, spoke about Ozempic. Now these are GLP-1 receptor agonists, anti-diabetic drugs. They also are used and abused for weight reduction, but these metabolic drugs also have had very positive effects in preclinical models of Parkinson's and Alzheimer's, and there is also epidemiological evidence, so users of these drugs have a lower incidence of Parkinson's disease, as well as dementia. So there were 2 positive phase 2 trials, one published in 2017 by the UCL group, my good friend Tom Foltini, and there was another one published just last year by the French group with lixisenatide, and both trials showed a significant difference between placebo and active. So, our hopes went up because for the first time we had not 1 but 2 positive phase 2 trials. But you know, in trials, you have to do phase 1, you have to do phase 2, but what matters is phase 3. And the phase 3 trial of exenatide, published just last year, was completely and utterly negative. It was in fact so negative that the field adopted a new term when we speak about clinical trials, and people say it was negative. We ask, okay, but was it exenatide negative? The last few years, oh yeah, and why is that? You know, why is it so difficult to find a cure for Parkinson's? And the same could be said for the other neurodegenerative diseases, I think. The field, I think, agrees that these reasons here play a big role. One may be that we don't know the target. We don't understand the pathogenesis of these diseases, and thereby perhaps we're attacking the wrong targets. Okay, it makes sense to attack alpha-synuclein, neuroinflammation, mitochondrial dysfunction, but we do not in fact know that these are the culprits. Target engagement. Maybe we are choosing the right targets, but we're not hitting the right targets. So, and this is important, you know, how can we make sure that the drug we're giving does in the human brain the same thing it did in the rat or the mouse brain? Many targets, right? Heterogeneity, what we call Parkinson's disease, what we call Alzheimer's disease, may not be one disease. In fact, most evidence suggests that it's not. Most evidence suggests that it's many diseases. However, to date, we're not able to stratify like we did with cancer, for example. And in cancer, we know that this led to a revolution in terms of therapeutics. We're not able to do this in neurodegeneration. Yet another problem is a practical one. So, you know, if any of you here work with biomarkers, this is important. We need you because we have very poor efficacy measures. We're testing treatments, but we don't have sensitive and specific ways to detect whether our treatments work or not. So there's an error margin. And of course, it may be too late. So when we intervene in these diseases, too many neurons have been lost, and snowballing processes, irreversible processes, may already be at play in the brain. One of the things that we have been doing at my center, one of our ideas was to use a slightly different strategy. So the treatments that have been tested until now for Parkinson's, they specifically attack specific mechanisms and processes. Here we thought, what if we instead focusing on increasing neuronal resilience? So basically imagine that, you know, your brain is a castle and you know that the enemy is out there and they're hiding in the forest, and the enemy is, you know, they're hitting the castle, they want to take it, but the problem is you don't know who they are and you don't know where they are because they retreat and they hide among the trees. So you have two options. You could ride out and try to find the enemy and kill them, or you could try to strengthen your walls, right? So this is more a strategy to strengthen our walls, to make neurons more resistant to disease-related stress. And our strategy for doing this was to increase the levels of NAD, nicotinamide adenine dinucleotide, a fundamental molecule essential for all life. It's essential for energy metabolism in mitochondria. It donates, NADH donates electrons to mitochondrial complex 1. It is also essential for a number of other vital processes. DNA repair is one of them. Inflammation regulation is another one. So, in fact, NAD is absolutely essential for all bioenergetics. It's essential in bacteria, it's essential in yeast, and had it not been for NAD, there would be no beer or wine today. So it would have been a very sad world. So what we've done here is we've started with a phase 1 trial. We assessed our target penetration and engagement. Can we enter the human brain? Can we increase NAD levels in the human brain? And can we have a metabolic impact? This was 30 patients, double-blind design, so neither we or the patients knew who's on placebo and who's on drug. Long story short, this is just an example of our trials to show how it usually goes. What we found was that indeed there was no change in the placebo. In the active drug, we had a highly significant increase in the levels of NAD in the brain. This was measured using magnetic resonance spectroscopy, a very nice technique, measuring phosphorylated molecules. And also we observed that the people who had the highest NAD increase in their brain, they also had a small but significant clinical effect. Of course, these are small trials. The clinical effect, you can just forget about it. This is an interesting observation, nothing else. Using FDG PET, we were able to see that there was a metabolic impact. I'm not going to go into the details, but together with the collaborators in New York, the Feinstein Institute, there was a network induction in the brain induced by NAD levels, and the induction of that network was correlated with a clinical response, which we also found to be, you know, positive or encouraging. We also looked at gene expression profile and protein expression profile, seeing that indeed NAD does what it's thought to do. It upregulates mitochondrial processes, but also proteasomal and lysosomal and proteasomal processes, which are important for this disease. So we've done a number of other trials just to document safety better, to find the range and the dose. It doesn't matter, I'm not going into the details here. What matters is that having done these trials and having done also some mouse and more preclinical work that I don't have the time to get into here, we now had a hypothesis that NAD replenishment may be a multi-target therapy. It influences mitochondrial metabolism, proteostasis, including the misfolding of alpha-synuclein, also neuroinflammation and DNA damage. So what we did here is we proceeded with a phase 3 trial, and this is a rare thing because phase 3 trials are usually done by the industry. This is an academic, publicly funded phase 3 trial, 12 centers, all university hospitals in Norway and some non-university hospitals, 412 patients, so that's a mistake, 410, apologies, patients were recruited in total, and they were randomized to either placebo or active treatment, a very high dose of NAD replenishment therapy. They were followed for a year. And that trial is now completed. We're in the process of closing the trial and locking the database, and this causes me quite a lot of sleepless nights at the moment. We have a small crisis management every day, but it's going forward. So I hope that we will have results from this trial within the coming 2 or 3 weeks. When developing drugs, sorry, some of this is in Norwegian, but when developing drugs, when testing drugs, we do this in collaboration with the industry. And when we do academic trials, it is important to cover all bases. One thing is, of course, that the science is the most important thing. Find something that works. But that's not enough, because if you find something that works as an academic, who is going to produce it? Who is going to put it in the pharmacies? I mean, we can't do that. We're a university and a hospital, public hospital. So here, the industry is important. Having a good, transparent collaboration with the industry. In this case, we have found an industry partner. We have licensed the patents that we have for this treatment. And this industry partner is now ready, if the trial is positive, to take it to the regulator and then to produce it and put it in the pharmacies if it's positive. So this is important. Otherwise, we can't reach the patient. How am I on time? Few minutes, yeah? I think. No? Yes, thank you. Oh, 7 minutes. Wonderful. Plenty of time. So the last part is about the new things that we're doing. Clinical trials are essential. Being academics doing clinical trials, yes, it made my hair white, but it was worth it. It's a nice adventure. But we also recognize that it's inefficient. The way trials are being done today is inefficient. So these are just some average numbers from the literature. Your average phase 3 trial takes 5 to 8 years, between 200 and 600 participants, sometimes more. It costs somewhere between 50 and 100 million US dollars. That is a lot of money, especially for academics. Not if you're Biogen or Roche, but we're academics, okay? I mean, we can do it a bit cheaper than that, but still, these are very expensive things to do. And also, this is important, the startups, right? Where do all these good substances come from? You ask people in the street, they'll tell you, oh, it's Roche, it's Biogen. If you go into Biogen's website and look at all the drugs they have, you will find somewhere in a corner, you have to search quite well, where they bought it from. And every single one is bought from a startup company. It is the pharmaceutical startups that have the cool stuff. However, the startups struggle. Most of them die in the so-called, valley of death, and they struggle to find VCs, to find venture capitalists who can support these treatments. So what we do is we work with these people, and we try to give them the opportunity to test their drugs on an academic platform. And to increase efficiency, I've been thinking of this for many years. How can we do this more effectively? How can we do it more efficiently? How can we do more clinical trials, more patients in trials at a lower cost, and also attract these startups and help them? And as I often do when, I'm in this situation, I ask, what would Ozzy do? And Ozzy was quite clear in my head. What he would do is platform trials. He said that quite clearly. And so did we. So we're now in early 2026 starting this very nice initiative. It is a national and international initiative, 2 platform trials, where we will be testing multiple drugs simultaneously. And this is by no means our idea. This is stolen from the cancer field, but adapted from neurodegeneration. So we have a small platform called the Sleipnir. For those who wonder, what is that name? That was Odin's horse. Odin's horse had 8 legs. So this platform also has many legs or arms. And here, the purpose of this trial will be to test multiple compounds, not only synchronously, but also in non-contemporary cohorts, and assess whether they get into the brain, and if they get into the brain, whether they affect, whether they influence the biological processes they're supposed to influence. So target penetration and engagement. Why are we doing this? Because of gatekeeping. The ones that do not do that should not proceed in efficacy trials for Parkinson's or, in fact, other neurodegenerative or brain diseases. And then Hydra's big sister, and this is inspired by Greek mythology now, Sleipnir's big sister, Hydra, which is inspired by Greek mythology. This was the mythical beast with many heads. It has nothing to do with Marvel Universe Hydra, okay? This is Greek mythology, the beast with many heads. When Hercules was chopping off one head, 2 heads came out instead, right, to replace it. So Hydra is a fully pledged phase 3 multi-arm, multi-stage platform. 3 drugs will be tested in parallel compared to a common placebo group, and futility interim analysis will tell us whether these drugs seem to be promising or not. When they don't seem promising, the head will be chopped off and new heads, new drugs will be put on the platform. So these things, these bold things are starting in 2026. We're not alone in doing these things. The 2 Norwegian platforms stand side to side with the French platform, NSPARC, the British platform, EJS-ACT-PD from UCL, and the US-based P2P and the Australian Parkinson's Mission. We call ourselves, all of these people together, the Global Coalition of Trial Platforms for Parkinson's. We meet each other a couple of times a year, and of course we compare notes, which is essential. So last, and I'm finishing with this, I wanted to show this man. Do you know who this is? Does everybody know this? Who this is? Yeah? Doctor Who? So Doctor Who was one of my childhood heroes, and he travels back and forth in time, right? He has a time machine, the TARDIS. And this is what we want to do here in neurodegeneration. We want to travel back in time. We want to intervene before the disease becomes the disease, because it may be too late otherwise. This is Parkinson's disease, and this x-axis here shows the development of the disease, the motor symptoms in purple, and the non-motor symptoms in blue, green, whatever this is. You know, you can see here that time point 0 is the time of diagnosis. And the time of diagnosis, of course, coincides with the onset of the motor symptoms, because without motor symptoms, you cannot diagnose Parkinson's disease. However, you may also notice that the non-motor symptoms may have started already 15 or even 20 years before the onset of the motor symptoms. And we can recognize these symptoms so that we can study and intervene before Parkinson's disease is Parkinson's disease. And there's particularly one form of symptom, REM sleep behavior disorder, RBD, REM sleep behavior disorder. This is a condition in which people act out their dreams. When you dream, when you are in REM sleep, your muscles are paralyzed. They have to be paralyzed so that you don't act out your dreams, and this is good because we dream a lot of weird stuff. Now, when you have RBD, REM sleep behavior disorder, this mechanism does not function, and people act out their dreams. Most typically, it results in violent behavior while asleep. They can hit their bed partner. People end up sleeping in separate beds. And let's see, can we click on the video? Thank you. It will start, yes. So this is just a video. No, it's okay. It's just click one more time. That's it. It will start on its own. Yeah, thank you. So this is not one of my patients. It's just from online. So this gentleman is asleep. Okay, this gentleman is not awake at any time during this video. As you can see, he is defending himself against attackers who are there in his dream. So this is typical REM sleep behavior disorder. All right, it happens under dreaming. This is not sleepwalking. Sleepwalking is benign and not associated with any risk of neurodegenerative disease. Sleepwalking does not occur during dreaming, but this occurs during dreaming. And when you have this, there is a more than 90%, more than 90% chance to develop Parkinson's disease or dementia with Lewy bodies within 15 years. So in fact, this is not just a risk factor, this is what we call a prodromal state of Parkinson's disease or dementia with Lewy bodies or multiple system atrophy. And it can be used, we can identify these people so that we can intervene early. So we're starting now a national effort in Norway, it's called NOR-RBD. So we just had this funded, and we will be recruiting people with this disorder. We need to do polysomnography to detect this EEG and EMG at the same time, and looking at breathing and pulse and so on. And then we will be enrolling them in clinical trials to see whether we can prevent the onset of these diseases. So this is something we're very excited to do, and nobody knows how to do this really, so it's unknown waters, and we're very happy to be doing that. So this is just my last slide. This is what we're doing. This is a map of Norway. It's a country with only 5.5 million people, but it's enormous in geographical size. And I was just telling my friend last night that from Bergen to Tromsø up there is almost a 2-hour or more flight. It's it's quite a big country. And this is the state of things. We have large trials, more than 30 trials ongoing right now, large number of patients enrolled, and we hope that this will only go upwards. So with this, I'd like to thank you for your attention. And So I won't take more of your time. I just wanted to say that, again, to thank everyone at the faculty for the invitation. When I came to Norway, when I came to Hungary, when I came to Szeged in 1997, I was 17 years old. Okay, I was 17 years old. I was a kid. And this is important because Szeged, it formed me. When you're so young, Szeged formed me. And it formed me in good ways, both scientifically, with a very strong faculty, and it formed me as a person. And this piece is always in me. It will never, ever go away. So when I look at you, faculty members, and those who are here today, but also those who are not here today, thank you.
Okay, thank you very much, Professor Zulis Haris, for your kind words. Okay, our final speaker is Professor Shilpa Srinivasan, class of 1996. She's a professor of psychiatry, vice chair for medical staff affairs, and training director of the Geriatric Psychiatry Fellowship at Prisma Health Midlands University of South Carolina School of Medicine. She completed her psychiatry residency at Tulane University, where she served as chief resident, followed by a geriatric psychiatry fellowship at LSU Health Sciences Center. Her clinical focus includes dementia, late-life mood disorders, integrated care, and telepsychiatry. Board certified in both general and geriatric psychiatry, Professor Srinivasan is deeply engaged in clinical care, education, and leadership. She's currently president-elect of the American Association for Geriatric Psychiatry and has received numerous honors, including the APA's Jack Weinberg Memorial Award for Geriatric Psychiatry in 2023 and the AAJP's Clinician of the Year Award this year. Please welcome Professor Shilpa Srinivasan with her lecture, Updates in the Assessment of Neurocognitive Disorders from Bedside to Biomarkers and Beyond. Yeah, sorry.
Thank you. Thank you very much for that kind introduction, Andrea, and thank you all for this opportunity. Words fail me to express just how much of an honor this is. The words fail me in English, so I'm going to try to say this in Hungarian. So, szeretném kifejezni őszinte hálámat Lázár dékán úrnak, Peták professzor úr és Bári professzor úrnak, és az Orvostudományi Egyetem oktatóinak a meghívást, hogy előadást tartatok ezen a találkozón. Megtiszteltetés számomra. Ahol ma tartok a szakmámban, annak a szilárd oktatási alapnak köszönhetem, amit itt kaptam. Ezt mindig magammal viszem. A mai napig hálás vagyok. És elnézést kérek a kiejtésemért. Okay, with that, I'm done. Not quite, but I realize I'm keeping you all from the evening events, so I will go as swiftly as I can. Thank you again to the faculty for this opportunity, to the medical students here. I will echo my sentiments, colleagues, to say cherish your time here. It goes by very fast, and who knows, at the next reunion, some of you may be standing down here delivering this presentation. So with that, these are my objectives. I'm going to be talking about neurocognitive disorders, and we'll discuss neurocognitive disorders in brief, but a big focus of mine is really going to be through the lens of Alzheimer's disease and discussing the emerging role of biomarkers in its management. In 2021, the World Health Organization issued its global status report on the public epidemic that is dementia. And in looking at the projections of persons living with dementia worldwide, back in 2019, there were about 55 million individuals living with Alzheimer's disease and related dementias. By the year 2050, that is projected to increase to 139 million, which is a 2.5-fold or 150% increase. So this is truly a global epidemic. In the United States, where I live and work, this is the data from the 2025 Alzheimer's disease facts and figures. This is a national document that is produced every year by the Alzheimer's Association, and there are over 7 million individuals in the United States living with Alzheimer's disease and related conditions, and women are at particularly higher risk, and the prevalence increases sequentially with advancing age. So age is really a memory thief in very many ways when it comes to conditions like dementia. When we look at the global prevalence, this was the Global Burden Disease Study, also in collaboration with the World Health Organization. You can see there is not a single part of the world that is untouched by dementia or Alzheimer's disease. So this is really a very concerning situation. And when we look at this through the lens of the World Health Organization regions, we can see that the Western Pacific region actually has some of the highest prevalence of dementia and related disorders, followed by the European region, and then the Americas. Briefly, again, where I live and work in the United States, we are an aging nation. And so the population prevalence and projections really show that the percentage of individuals in middle and older adulthood is progressively rising, and by the year 2060 is projected to change what is called the population pyramid, from a pyramid that you see here to really a pillar. So much so, in fact, that in just the next 10 years, by 2035, individuals in the United States age 65 and above are projected to outnumber individuals under age 18. So there's really a demographic imperative to address the needs of individuals with dementia, but also to address the condition itself. And as I said earlier, age is one of the biggest risk factors, with the prevalence of dementia rising exponentially with each advancing age cohort after age 65. So what are we talking about when we use the term dementia? You may also hear it being referred to as neurocognitive disorders. And essentially, what we're looking at here is a condition that is represented by changes in cognition, sometimes referred to as memory changes, along with functional and behavioral changes. And the sine qua non of a neurocognitive disorder is that these changes represent a decline or a change from a person's baseline functioning. And with most dementia syndromes, the change is gradual or insidious, and it progresses over time. So this is a progressive neurodegenerative condition. Unfortunately, as we heard from the previous presentation as well, sometimes the subtle memory or cognitive changes can really predate the significant functional changes, so it can delay diagnosis by several years, if not decades. With dementia syndromes, what we know is that it's an umbrella term, and oftentimes dementia is used synonymously with Alzheimer's disease, but Alzheimer's disease is just one type of dementia. There are other types, including frontotemporal, Lewy body dementia, vascular dementia, but the reason I'm focusing more so on Alzheimer's disease is because that is one of the most prevalent forms of dementia worldwide. What we know is that usually, in the clinical setting, having an informant, meaning a reliable family member, an adult child or someone who can give some information about the chronology of events in the decline of a person suspected with a neurocognitive disorder, it's valuable to have that collateral, but unfortunately, sometimes that collateral is not available. And so the condition becomes indolent and unrecognized until the bottom drops out. Or in the case of one of my patients, the family really didn't think there was anything wrong until mom was driving down the highway the wrong way. So it was hard to ignore the signs then. And we know also that it's less likely for self-reported memory loss to be common. So it's usually not the patient who's coming and saying, you know, I have neurocognitive issues or memory problems. It's oftentimes family members. So where were we when it came to the assessment of Alzheimer's disease-like disorders? It used to rest very firmly in the bedside, meaning once the symptoms manifest, once persons started becoming forgetful, then the investigations would start. Sort of like what we heard in the previous presentation. When the motoric symptoms of Parkinson's disease manifest, that's when the disease is diagnosed. So what did we do at the bedside? Everything starts with a history, right? Everything starts with the anamnesis. So you take a clinical history, you take a history from patients and their family members to try to get a sense of what started, what's happening, what's going on, what are the symptoms the patient is presenting with. And it's important not just to take that history of present illness, if you will, but also to get collateral information, get medical histories, get family histories, get social histories. So we start with gathering a history, and then we try to establish a timeline of events. How did the symptoms begin? When did they begin? Did they begin suddenly? Did they develop slowly? What caused it? Was there any precipitant? Was there a surgical event? Was there a medical event? Was there some other event? And how has the memory loss progressed since then? Has this been insidious? Has it declined? Has it been a stepwise decline? All of these are questions that we ask at the bedside, meaning this is part of the clinical assessment. We then do something called a functional assessment, which is just a fancy way of saying, what can the person do for themselves, by themselves, independently? And we stratify a functional assessment in terms of basic and independent activities of daily living. These are just daily processes that all of us do on a regular basis, but we need intact cognitive function for these processes, and the degree of cognitive function that we use for these processes can vary. For example, when you think of basic activities of daily living, like feeding, like toileting, like ambulating, not a lot of thought needs to go into that. Some of that may be fairly reflexive. But then you have something called instrumental activities of daily living. These are higher order thought processes that rely on something that we call executive functioning. These are more complex cognitive tasks like driving, like managing finances, like preparing a meal. All of these require planning, sequencing, organizing. And we start seeing erosion in functionality, and that's why we need to do a functional assessment in order to establish whether or not this is a change from baseline. Remember the sine qua non. And then we embark in an additional clinical workup, and this may include things like blood work to rule out reversible causes like poorly supplemented or undiagnosed hypothyroidism or vitamin B12 deficiencies. We may order structural neuroimaging tests like a CT or an MRI scan, maybe a sleep study, and maybe neuropsychological testing. But at the bedside, if you will, these are all still predicated by some fairly subjective measures. And the reality is more people are missed than they're diagnosed because we wait until the symptoms begin in order to make the diagnosis, whereas things may be happening in the background. In order to establish that background, we need to have an idea of the timeline to see what is it exactly that's happening in a situation like Alzheimer's dementia. Well, it was actually named after this gentleman, Dr. Alzheimer, who in 1901 described a case of his patient, a 55-year-old individual who had confusion, memory loss, and paranoia. And in the course of treating this individual, when she passed away, he then published a series of literature and some of the very first case reports on Alzheimer's pathology in 1907. Now, Dr. Alzheimer, at the time, not only being a physician, but also being a pathohistologist, obtained brain biopsies and identified at that time what we now know to be some of the pathohistologic hallmarks of Alzheimer's disease, which are neurofibrillary tangles, intracellular, intraneuronal accumulations of hyperphosphorylated tau protein, and extracellular amyloid plaques. Remember these terms, plaques and tangles, amyloid and tau protein. These were the first microscopic signs of what we now suspect to be part of the pathology involved in conditions like Alzheimer's disease. But you also have, obviously, the macroscopic or gross anatomic findings, which include cerebral cortical atrophy, which you see here depicted in this graphic, where you see on the left you've got an intact brain, and on the right, a highly atrophic brain with really widened sulci, narrow gyri, vacuolation of the ventricles, and hippocampal atrophy. Subsequent to this 1907 timeline, as the 20th century progressed, there were more studies that evaluated and determined some of the conditions that are the underpinnings neurobiologically of this condition, which includes adverse impact on the cholinergic neurons in the brain and loss of cholinergic neurotransmission, which really heralded the onset of essentially the investigations into a condition that for the last 20 plus or so years has really not seen very many advances in pharmacotherapeutics, but that is rapidly changing, and it's about time. There are challenges to timely clinical diagnosis. There are challenges to this bedside diagnosis, right? One of the challenges is that these pathohistologic hallmarks, the tau tangles and amyloid plaques that I just talked about, these are very firmly in the CNS. They degrade when they cross the blood-brain barrier, so testing for these is challenging. How would we test for it? Well, the gold standard was brain biopsy. Now, I don't know about the current medical students, but I know that when I received my excellent medical education here, I did not trephinate anybody's skull, and I did not do any brain biopsies, and they didn't teach me that during my residency or fellowship training either, and I think my patients are very relieved for it. So just saying, we can't rely on just these pathohistologic hallmarks to be the gold standard. It's also, there are some other challenges as well. It's clinically difficult to recognize the disease in early stages. Sometimes family members minimize, inadvertently and non-maliciously attribute it to normal aging, or, well, anybody can be forgetful. But this can, again, delay diagnosis. And while the clinical diagnosis becomes apparent when most or more cognitive domains are affected, this progression from these early warning signs to disease manifestation can span a decade or longer, and that's a lot of time lost. So we really need to migrate then from this continuum of conceptualizing this condition as Alzheimer's dementia, which really is once the symptoms start, to moving past this to really looking at this through the lens of disease progression, which really begins preclinically up to 20 years beforehand with some non-cognitive changes, to then developing what was called a prodrome of mild cognitive impairment, a condition that sort of straddles, if you will, preclinical and dementia. There's a risk of conversion of mild cognitive impairment, or MCI, to full dementia with 5 to 10% increase every year potentially. So there's a lot of time where we really need to intervene, and this is where biomarkers come in, and this is where my talk will really focus on where we were, which is here disease state-wise, to really like looking at now going through this continuum and evaluating the role of biomarkers in diagnosing this condition. This graph kind of highlights why. This is where we were at the bedside in diagnosing cognitive impairment. And as you can see, a lot of time has spanned. So by the time a patient presents with symptoms that are suggestive of MCI or dementia, the cat's already out of the bag because, again, a span of several years has passed. But if we look at biomarkers, those can potentially cue us to evaluating a person and maybe following them more closely to see if they are more likely to develop the full-blown manifestation of this condition. So with that, I'll talk a little bit about what these biomarkers are. Oops. So the National Institutes of Health defines biomarkers as entities that can be objectively measured and evaluated as an indicator either, I'm so sorry, I have no idea why my slides are doing this. All right, there we go. Evaluated either as an indicator of normal biological processes, they can be a sign of pathology, or they can be used to track response to treatment. So a biomarker, the presence of a biomarker can indicate normal process. The level of a biomarker can indicate pathologic process. And monitoring of that level of biomarker can indicate response to treatment. An example of a biomarker, just a common biomarker, would be hemoglobin A1C. It's a biomarker used for diabetes, right? If hemoglobin A1C is below a certain threshold, it's normal. You're not diabetic. If hemoglobin level, A1C level is elevated, you can have prediabetes or diabetes. So it's a marker of pathologic process. But if you're being prescribed treatment for diabetes, your hemoglobin A1C is tracked, and it can indicate how well you are responding to your treatment. So hemoglobin A1C is an example of a biomarker. What about for Alzheimer's disease and related dementias? Well, as I mentioned earlier, the definitive diagnosis used to be brain biopsy, right? So that was the gold standard. What we really need are validated biomarkers to accurately diagnose this disease, meaning having a high specificity in the early stages in which disease-modifying therapies can be applicable. You heard about disease-modifying therapies for PD. Well, this is very much the era in which we are right now for some other neurocognitive disorders, including Alzheimer's disease as well, with varying targets and efficacy. So what would we consider the ideal biomarker when we're talking about Alzheimer's disease? Again, I don't think any of our patients are going to be coming to us for us to do brain biopsies, right? So what is the perfect biomarker then? The perfect one is something that can be easily obtained, either a biofluid biomarker, like blood, saliva, hair, skin, nails, and that is accurate with high sensitivity and high specificity. So you want a high true positive rate and you want a low false negative rate. But these are the challenges. The dementia pathology that is very much behind the blood-brain barrier, and some of these CNS biomarkers that degrade once they pass into the bloodstream. So what we also need these biomarkers to do clinically is to, number one, accurately determine when someone has MCI, or that prodrome, versus Alzheimer's disease. We want it to be able to tell us who's in which stage and when, and we also want it to allow us to prognosticate better. We also want it to differentiate Alzheimer's from non-Alzheimer's types of dementia. And lastly, we want it to be able to identify patients who are at risk for developing this amyloid pathology. So again, intervention is key. So we need a very targeted approach. And as you heard from the previous presentation, sometimes the targets are variable, sometimes the strategy to hit the target is variable, and sometimes there are just too many variables than targets. So with that, I'm going to talk a little bit about the biomarkers in present day, current state, when it comes to Alzheimer's disease and related dementias. We can conceptualize biomarkers as being either biofluid-based, imaging-based, or electrophysiologic biomarkers. For the purpose of this presentation, I'm really going to focus on biofluid and imaging because that's more in current state clinically and less restricted, if you will, to just the research realm at this time. So when it comes to Alzheimer's disease, what are some of the imaging biomarkers? And by imaging, I'm talking about both structural and functional neuroimaging studies, so CTs, MRIs, and functional neuroimaging studies like PET scans. What do we not not too terribly specific, but one thing that can be seen is disproportionate hippocampal atrophy versus atrophy of the other areas with a sparing of the primary motor and visual cortices. So really on an MRI scan, what we're looking for is not just atrophy, but what we're looking for is specifically hippocampal atrophy, and the best way to actually view this is in the coronal plane, not in the axial or sagittal planes. What else can we see? We see some cortical atrophy that's nonspecific. If we were to order functional neuroimaging, which is an FDG PET scan, FDG is fluorodeoxyglucose, which is brain food. So this is a radioactive ligand that is administered intravenously, and the brain takes up this brain food in areas that are working well. What happens in Alzheimer's disease is there's a predilection for the temporal and parietal lobes, so these areas are hypometabolic in their activity. So when you have a PET scan, when you administer a PET scan to a patient with possible Alzheimer's disease, the areas of the brain that are going to show up as cold spots would be the temporal and parietal areas, because there's loss of neurons in those regions. So these are some imaging biomarkers, meaning tools that can be used objectively to measure or determine the presence of pathology. We are also moving from some of these imaging biomarkers into the area of actual amyloid and PET neuroimaging study, amyloid PET and tau PET imaging studies, where there are radioactive ligands that bind specifically to amyloid. If you'll recall, I talked about those pathohistologic hallmarks being amyloid plaques and neurofibrillary tau tangles. Well, there are now compounds that can be administered that actually bind to amyloid in the brain, and the presence of these is suggestive of Alzheimer's pathology. What about biofluid markers? Well, up until essentially a couple of years ago, the main biofluid marker for Alzheimer's disease was the cerebrospinal fluid. So patients had to go have a lumbar puncture in order for these to be measured. And the CSF levels of amyloid beta 42 and tau proteins in certain ratios were suggestive of amyloid pathology. Now again, an LP is an invasive test. And it's very difficult sometimes for patients not only to tolerate it, but to buy into having to undergo an invasive test for determining diagnosis or next steps. So we really need to, and have been very focused on moving ahead with this to see how best to intervene, but how to simplify detection in a way that is least invasive. So in 2018, the National Institute on Aging and the Alzheimer's Association came up with a framework called the ATN Biomarker Framework to look at Alzheimer's disease through the lens of amyloid positivity, tau positivity, or neurodegeneration positivity. How does this work? So on amyloid PET scans or CSF studies, if there is amyloid positivity seen, then that scan would be considered A positive. If not, it's A negative. If on CSF studies or tau PET scans, tau pathology is seen, that would be T positive. If not, that's T negative. The neurodegeneration or neuroinflammation or neuronal injury is predicated by structural neuroimaging, like an MRI scan or an FDG PET. And so what you see here is this ATN framework where undergirding this is A positivity. So anyone with amyloid positivity via either CSF studies or amyloid PET are suspected of having Alzheimer's disease. Now, this has come under some scrutiny because there are some schools of thought that say, hey, it's not just the amyloid story. There's more to it than just resting your eggs in the amyloid basket, if you will. But this is what started some of the initial processes to look at the role of amyloid in diagnosis as a biomarker. So this is an example of what this ATN framework would look like. On the top left here, this is an amyloid PET scan. The areas in red and yellow are suggestive of amyloid deposition. You see a lot of red and yellow on this PET scan. On the top right and bottom left, these are tau PET scans. Areas in red and yellow are suggestive of tau deposits in the brain. So you see quite a bit of red and yellow over here as well. So this would be A positive and T positive. And on the bottom right, this is a standard MRI. What you see here on this is hippocampal atrophy, and you also see significant cerebral cortical atrophy as well. So this according to this framework, this individual would be A positive, T positive, and N positive. And these images are from the Mayo Alzheimer's Disease Research Center. This was a 75-year-old woman with amnestic multi-domain dementia. In contrast, over here, this series is A positive, T negative, and N negative. So on the amyloid scan, you do see some amyloid deposition, areas of mostly yellow, some red. But on the tau scan, it's negative. There are no yellow or red areas. There's no tau uptake. And on standard MRIs, there's no atrophy yet. So this is actually a preclinical Alzheimer's picture in an individual who did not have memory loss or cognitive disturbance symptoms yet. So this is where some of these biomarkers can really help with the prodrome, if you will. There are also emerging areas of use of biomarkers in non-Alzheimer's type pathology, including things like frontotemporal dementia, dementia with Lewy bodies, and other conditions, predicated by where the imaging results show signs of pathology. For example, as compared to normal or controls, in Alzheimer's disease, you see significant hippocampal atrophy, but you don't see that in FTD or dementia with Lewy bodies. What you do see in FTD is significant frontal and temporal pole atrophy. You don't see that with Alzheimer's disease. So this is the way imaging biomarkers can be helpful in looking at and helping to differentiate some of these conditions, and this is the case with some of the PET scans as well. It is absolutely not 100%, of course. We do need to ensure that we keep other variables in mind. So when looking at this as an amalgam, here are some of the blood-based biomarkers now. I'm shifting from imaging to blood-based. Here are some of the blood-based biomarkers that are being looked at in Alzheimer's disease. So these are blood tests to determine levels of amyloid pathology and tau pathology. So tau pathology biomarkers that you see here, amyloid pathology biomarkers that you see here, and some other neurodegeneration and neuroinflammation biomarkers that are in the research pipeline to be studied. And how does this compare then to, let's say, a lumbar tap or imaging studies? You can see that there are some correlations and there are some common patterns. So elevated amyloid on PET or tau. We also have blood-based biomarkers that show elevated tau pathology and amyloid beta 40 to 42 ratios that are suggestive of amyloid and Alzheimer's pathology, which is pretty compelling, the idea of being able to utilize something like a blood test versus invasive measures like spinal taps, etc. I'm going to move through this pretty rapidly. I've already talked about blood-based biomarkers. p-tau is one that's actually emerging in clinical use. This is one that we use in our clinics and order in our clinics actually as part of the neurocognitive workup. Briefly, here are some others that are coming down the pike maybe. These may be future targets. The ones in green are ones that are currently available. Some other ones that are looking at neurofilament light chain and neuronal damage are slowly emerging as well from the research arena, but there's a lot more to go. And so this is a rapidly evolving area of research. But at the end of the day, what we really need as that ideal biomarker is something that is simple to administer and will accurately address the condition that we're trying to look at. And so that evolution is mirrored in what we've seen in the evolving conceptualization of Alzheimer's disease from the lens of research to the clinical area. So we are clinically also evolving from diagnosing this condition based on the symptomatic model of when a patient presents with these conditions to really utilizing things like biomarkers and genetic risk stratification, particularly for some of the early onset Alzheimer's disease conditions that have a high degree of heritability, to really refine our diagnosis and enhance our opportunity to intervene for a condition that is really relentless. So we're really looking at this point where we are is emerging into this era of utilizing biomarkers as part of the clinical and functional assessment and really bringing this to the bedside in a much more strategic way. From the Alzheimer's Association, some new staging frameworks have been suggested. So building from that ATN framework, but really moving into utilizing some of the staging of amyloid and tau biomarkers. What does this mean for us clinically? We're moving from this area of taking a history and maybe some blood tests to actually moving through imaging and biomarker access, hopefully to refine our treatment, which includes but is not limited to medications that are non-disease modifying, like the cholinesterase inhibitors, but also looking at lifestyle changes, clinical trials, and disease-modifying therapies. This is fairly hot off the press. Some of these clinical practice guidelines were published earlier this year to look at the role of imaging biomarkers, but what I'm going to do is just essentially highlight that at the end of the day, these tests should really be patient-centered shared decision-making, and it's important for us to utilize these paradigms, but we have to remember, at the end of the day, we have to consider the needs of our patients, and we have to consider our imperative, which is do no harm. Blood-based biomarkers, this is a very busy slide, but there are, again, quite hot off the press. This is from July of this year, a publication that talks about the role of biomarkers in specialized settings and using blood-based biomarkers like p-tau assessments, corroborating that with amyloid and tau PET imaging, but always putting the patient first. I'd like to end here by my acknowledgements. Again, I would like to thank Dean Lazar, Drs. Petak and Bari, and the faculty here for this opportunity. I would also like to acknowledge and recognize my professors in psychiatry and neurology when I was here, who really, really got me interested in neurosciences. These were Professors Zoltan Janka, Dr. Vece, and Dr. Benedek. I'd also like to thank Andrea and Vanda and Esther for their support here. All of my professors, mentors, colleagues, and friends for some incredible experiences here in Hungary and a treasure trove of memories. And I'd like to dedicate this presentation to my parents. They took a huge leap of faith when they sent a 16-year-old me to not just another country, but another continent to go to medical school. And I don't know that I would have the guts to do that with my child. But this presentation is important and near and dear for me, not just because Alzheimer's disease and related dementias is something that I see and treat, but because my father is a person living with dementia. This is a condition that affects persons, families, communities, and societies at large. And so I'm very gratified to be living in an era when there is so much work being done in the realm of neurocognitive disorders, and I hope that some of you will go into this field as well and contribute to a very, very deserving condition and eradication of the same. Thank you for your time.
Thank you very much. And the talks are finished, but the session we have still about 10 minutes. I'm looking at Andrea if I'm correct or not. So please come, the speakers sit here, and while they are having their seats for the next 10 minutes, I would like to apologize first. Of course, I didn't want to mislead you at the beginning of this session about an hour ago about Professor Marta Széll. He is a vice rector of the university and not the vice dean. I'm sorry about everybody. And that made me think about the second and the third and the fourth talk, whether my voice and the brains are completely dissociated. Is it a sign of early dementia or something? But they can tell me. Okay. I am a bit relieved. My question, and then I open this short discussion session, because there are students in the back row, and I'm pretty much sure that they are thinking about something similar. Here we have distinguished scientists, successful people in their national area and internationally. So what comes into their mind, this I'm sure, that what can they suggest if those current English-speaking students in the back row would like to follow their footsteps? academically, personally, what are the best part of the Szeged studies that can help them to be as successful as our distinguished speakers? Give the microphone.
Would anyone like to begin? Thank you, Dr. Petak, for that question. And you know, it's amazing to think of the time that has gone by, but also realizing that some of the foundational aspects of what we learn here are things that we all carry with us. There's so much of synergy between all the various topics of presentation that you probably saw as a common thread, and that common thread is just this passion for learning and for serving patients clinically that really starts here. That passion for learning is something that the faculty here have really instilled. I was curious from the current students if you all still have oral exams. Is that still a thing? It is daunting, isn't it? It's terrifying, but I tell you what, it is character building and it is strength building. I think you see us speaking today because we cut our teeth on those exams and these presentations, so embrace it, embrace the fear, because it really does build upon itself as part of the whole experience.
So I think you stole my thunder because I was about to say the exact same things. So for me, first of all, it was the knowledge, right? This fundament of knowledge that this university, this faculty gave me. And I was able to compare. So, you know, when I moved on to Norway, and it was also a relatively international place, and people had studied different places. So I could see that us who came from Szeged and potentially other Hungarian universities, we prevailed in terms of knowledge. We knew so much. The other thing, again, as I said, you stole all of my thunder, but the other thing is exactly what my colleague said, that the oral exams, how tough it was, how difficult it was. And it was difficult. I remember being scared. I remember I remember pulling these overnights and reading and reading and reading. Oh, what if I fail? Yeah, as you said, it's character building, and it made me able to endure difficult situations, because remember that even though it's tough, you're still in a protected environment. When you're done with your studies, then you're standing there with your patient, and this may be a life or death situation if you work in the ER, or it may be a situation with a chronic illness, outpatient, and so on. What you gain here prepares you also for the tough reality, because reality is tough.
I will say only one thing that I remember very much. After an exam with minus 19 degrees, that I was wearing high heels, black skirt, and very teeny shirt to appear to the professor. And when I passed the exam with 5, actually at this area behind, I took off the shoes and I was running in the street. So this is what Szeged, I think, create us, that we can pass over the obstacles. And I will tell my personal story that when I was back in Greece, maybe unfortunately I'm in the wrong place. There was always saying, oh, you studied to Hungary, and there wasn't any recognition. And they were saying, oh, you studied to Hungary, what she knows. But when we were speaking with my friends, that they were the same year in the university, in Athens University, and I was speaking about pathophysiology and what is the arachidonic acid cascade and all this, and what I was doing in the pathophysiology department, they were looking at me like that, and they say, from where you know all this? So I think the knowledge, the respect that we had here, I mean, how we have to behave as students, make us what we are today. Thank you very much. And try to keep it this and connect, because all of us, even the older with the younger, have the same experience and we behave as doctors the same way. And I think this is very important.
Thank you. I won't take long. I think first, from personal perspective, Szeged for me is my second home. And if there is one tip I want to give you, of course, you will have the knowledge and the skills. You will have a very good education here in Szeged. This is something that it's obvious. But if there is one thing, maybe I can give you a suggestion to take it with you. Learn some Hungarian. Because I can say that I'm fortunate that I speak Hungarian. And this made my life a little bit much better, I would say, even as a student. And I could communicate with, it's to integrate in a culture without a language, it's a problem. I think many of the foreigners, when they come here, they don't do it. So if you have the chance, it's hard, but it's not really hard. I mean, when you leave and you start work, you will understand how much time you have. So there is plenty of time to do things. And I think if you learn the language, you will be integrated more in culture, and something, if you can, just please do it. And I think at the end of the day, beside the knowledge and the medical school, I think all of us, and you will feel it, that really we are today in who we are. It's because of what this country and what this city gave us. It's to respect, to gain an exam with a tie. This morning I was thinking 5 times, should I put a tie or no? And I have it in my bag, but I don't know how to tie it. Really, it's here. I was thinking this is disrespectful to come without a tie, but I couldn't do it for 2 days. So it's these things, just to go in a professional way. And you guys, by the way, the Hungarians, you are very well organized. I know that it put you in a stressful, if you pass 1 minute pass and stuff. And yeah, so these things have made us, to be more organized, at least to try, and be in a place where you give a respect, and we owe this place a lot. And thank you again, each one of you.
Thank you very much. Thanks for the talk. Thanks for the truly inspiring thoughts for the students. Unfortunately, we have no more time to discuss, but what I would like to draw your attention that tomorrow afternoon there will be a Students Meet Alumni session here in the hall, where you can continue this discussion personally in a more private manner. So if you have any questions or something that you would like to share or discuss with our prestigious alumni, and this is not true for our lecturers, but all of the others, please come and meet them. Finally, I give back the microphone to Andrea, because she's telling you full practical type of information about rest of the day session. Thank you very much for your attention.
Okay, so let me conclude the session with the technical information. Most probably you have seen in the program that our next program is a visit at the mayor's office. We were invited by the mayor of our city for a visit. He is expecting us at 5 o'clock, and we will have a bus transfer. So a bus is waiting for us in front of the dean's office. So we will leave this building altogether in 15 minutes. Okay, so at 20, let's meet at the main entrance, okay, where we have entered the building. So you have around 15 minutes to have a coffee, a drink, restroom, and let's meet at the entrance at 20, okay, for 20. And please, those who need the CME accreditation, the course, the credits, give the papers to Wanda, okay? Thank you.